You can start speaking, Dr. Murthy. Probably the slides will take another 1 minute or 2 minutes to show.
Yeah, no, I have the slides. I'm showing
Yes,
it.
yes, yes, yes.
I will show the slides from my side.
Sure.
So, good morning, everyone. I'm Dr. A. This is my presentation. No? Yeah, I'm Dr. AS Murthy, a consultant nephrologist in Medihill Group of Hospitals, Kenya, and I'm happy that Dr. Manjusha and Gangadhar invited me to join the scientific session, and I'm very happy to see many of my colleagues, friends, seniors, teachers in the panel sitting over there. I feel sorry that I could not attend the session in person due to some local travel constraints. So this happened, I think, when Manjusha and Gangadhar met me last year when I went to Bangkok to present my transplant data as poster in World Congress Nephrology. So they then said that this year I might be speaking, addressing in the southern chapter of ISM. So that is the backdrop. And I came to Kenya 6 years ago to a private medical center, Medihill Group of Hospitals, and they started my nephrology work and transplantation work. And this story is not about the kidney services and in Kenya, because I'm in a private setup. And last 5 years, what I have done is mostly transplants. So this center, so today's my presentation will be of how I could bring up a simple medical center to almost now it is an international center for kidney transplantation in just a period of 5 years, achieving over 380 plus successful live kidney transplants, and with very, very limited resources. I had to struggle through. This is more about my story rather than an African or a Kenyan story. So I would like you to take you through my presentation about these are all single center, single physician, single surgeon, single anesthetist. So limited manpower, limited resources, limited lab, limited pharmacy, everything, but still we could achieve an international standard. And the next slide is going. This one. No, not this one. No, not this one. No, you take it out. No, wait. You'll get it. Just a few seconds. Huh? It's getting. Yes, please. So, as an overview, that all over the third world countries, particularly so in Africa, the resources are limited, and accessibility to medical care, quality medical care particularly, is limited. That is my overall observation. And dialysis is only offered twice a week, funded by the government. And most of these patients have no access to transplantation. And the transplantation is done in only very few private medical center and in one government center in Kenya, that is in Nairobi. And most of these patients I have watched over initial period that they have to go to India or South Africa or Egypt or any other European countries to get transplantation done. Even in Hyderabad, when I was there were so many people used to come from Africa for transplantation. I used to see their troubles really, which they go through, about the finances, about the stay logistics, about the expenses, so many things. So, with that backdrop, this hospital, Medihill Group of Hospitals, is a conglomerate of 6 or 7 centers across Kenya and neighboring countries. And the founder is Dr. S.R. Mishra, and his wife, Dr. Pallavi, both are gynecologists from India, settled here 20 years ago, and is also ex-MP of the place. So it is a level 6 hospital with many centers across Kenya and neighboring centers. Now we are into the 5th year of kidney transplantation, and only live kidney transplants are allowed in Kenya. Cadaver transplant has not yet started by the Kenyan government. And the way I started, even the software, the Excel sheets, everything I had to develop myself. I did not have separate transplant software. So I created my own protocols on my way completely. So I started capturing the data, both pre-transplant, peri-operative, and post-transplant, everything single-handed. I had to sit and develop completely myself. So to protocolize a program, I ran the program like a program rather than a private practice. So the patients here have limited access to cardiac consultation, cardiology reviews also. We started the cardiac program in our center, and all the patients undergo detailed cardiac evaluation by ECG to DEPO and angiogram in select cases, and DSC for all the patients. And we have done many patients and pacemakers also. We modify the settings of the pacemaker for the surgery. And during angiograms, we have found nearly very significant number of obstructive coronary lesions, and we do revascularization by angioplasty or bypass before we take them for transplantation. All these procedures is done in our facility only. So, and we devised detailed radiological evaluation, and including the recipient, I do a CT trunk protocol, which I have developed here from neck to pelvis, which will give every vascular structure, every anatomy in a 64 slice CT, and very detailed analysis I get about all the structures from neck to pelvis, including the vascular anatomy. And we do donor DTPAs and system EB nuclear scan for parathyroids if necessary, and some cases of stone diseases, hyperoxaluria panels, we send it to India. And the cross matches, this is one of the areas where initially a traditional CDC method we used to do in India, and then sometimes later we were doing by transplant by adding DSA to it. Later here, after coming here, I found for me, it was inadequate because I'm in a remote setting and I can't afford to have a rejection. And because even thymo is not available here, I had to get it from India in a very, very limited source, and it is very costly and unaffordable. So I had to switch over to, after discussing with transplant immunologists in India, so I switched over to all the methodology by default, every patient by NGS high resolution for 12 alleles, the typing, and CDC and D and B cells, and single antigen bid analysis for class 1 and class 2 antigens for all the patients without exception. So all the patients who have high DSA titers are more than 1,000 or 1,500 sometimes. I started desensitizing them by plasmapheresis and giving them IVIG before transplantation. And all the patients, we do pre-transplant vaccinations for hepatitis, pneumonia, and influenza. All the post-transplant data, I capture it myself every visit and enter into my Excel sheets, and my statistician analyzes these data for me. So in summary, around 2000 November 18 we started, and till to date I can say December and January there is some till December the last around 380 transplants we have done, except for a gap of 6 months during the COVID period. And 6 months we did not do transplants due to COVID logistics and restrictions. Later we restarted in September 2020. And then the program is still going on. I have 10 more transplants to do this month. So in that group, one of the things is many patients are above 60, up to nearly I can count up to 78. And the oldest is 78 years on paper, but actually practically I knew he's 80 years. So he's an Israeli patient. And the youngest was 8 years. And delayed graft function at discharge in about 76 patients. And infections, major infections, I could count to my knowledge up to 17, minor up to 16. And all the transplants were by default only laparoscopic. And deaths recorded to my knowledge were around 18. So during these evaluations by radiology and coronary angiograms, I could find so many of vascular anatomy anomalies of the aorta, iliac vessels, aortic aneurysms, dissections, and significant atherosclerotic plaques, and up to 80%, I can say 20%, 21%, and simultaneous pre-transplant native kidney nephrectomy plus transplant we have done in about 6 patients, and multiple renal arteries up to around 60 patients we could count, and lower urinary tract simultaneous repair was done in 7 patients. And anesthesia, there were a very high risk patients. There is a multiple overlap of obesity, OSA, and then thymo-induced ARDS, compromised lung function. And one of the most common problems was very high PAH levels, and requiring modification of the anesthetic technique. And patients with very high PAH and lung problems, our anesthesia team have done in transplant under epidural anesthesia in 7 patients. And in my overall immunological evaluation, up to 60%, I could say all patients had some degree of high DSA levels on SAB analysis. All the cross matches I do virtual myself. And when they submit the HLA NGS typing and the SAB results, I sit and do the virtual cross matching myself. And all the patients with high DSA levels, I desensitize them. I must have done around 400 or 500 sessions of plasmapheresis in these 5 years. And very high DSA levels, more than 3,000 also we have done. And very high, like 6,000, 7,000, we have rejected and asked for an alternative donor. And most of these patients have some degree of uremic cardiomyopathy in the form of severe left ventricular hypertrophy, diastolic and systolic dysfunction, and most common is the pulmonary arterial hypertension and valvular leaks of varying degrees. Now, what all these patients, it is a conventional twice a week dialysis program in this country. I first escalate them to 3 times a week dialysis before the transplantation. And if the patient is not doing well, or if the PAH is very severe, so I have started the hemodiafiltration in our facility. And I have seen marked changes, the pH coming down and the LV systolic function improving before the transplant itself, so that they are anesthetically more safe and they are transplanted. And nearly up to 120 patients, we have found at least some degree of occlusive coronary aortoiliac carotid vascular beds, and up to 25 patients had significant coronary lesions in our group, and then we did angioplasty for them before the transplant. And around 50 patients had severe secondary hyperparathyroidism, and I used to treat them medically. And 8 patients who were refractory and found to have parathyroid adenomas on system AB scanning, or if there is a diffuse hyperplasia with the refractory, we did the simultaneous parathyroidectomy and transplantation together simultaneously in the same sitting with intra PTH monitoring. So we monitored the level to how many parathyroids to remove, the surgical team, and we decide that way by intra PTH monitoring. And 1 patient required a hemithyroidectomy for multinodular goiter, and 1 patient superficial parotoidectomy for parotid gland adenoma. And in our series, there were 12 patients who were hepatitis B positive, 10 patients were HIV positive, 3 patients were HCV, and all these were successfully transplanted after control of viral loads and continuing the antiviral drugs post-transplantation. 10 patients received second transplant successfully, and graft nephrectomy we do if the DSA levels are high. Otherwise, we have not every patient we do the graft nephrectomy for the second transplant, and 1 patient, young boy from received the third transplantation. So all the patients received induction with hemoglobin up to 278, almost, that is 2/3, and 1/3 Similac and IV methylprednisolone and IVIG. And average post-op recovery time in these patients is 7 days. up to 5 to 10 days in 80% of the patients and delayed graft function in 76. And I had some acute, hyperacute rejections despite the DSA being negative in up to 7 patients in these 5 years. And we had 3 main renal artery occlusions. We could save 2. 1, the graft was lost. And I did require around 20 patients. I did acute graft biopsies and some 10 patients requiring for chronic graft dysfunction. And this is the serum creatinine mean in about 100 patients. My statistician has given me. We can see the means, the mean across the discharge at 1 month, 3 months, 6 months, and 1 year is well within the acceptable limits and shows a good graft function in all these patients. And also this is tacrolimus dose. We can see as the period increases from the time of transplantation, we could reduce the TAC doses significantly and we could maintain good graft function at a lower TAC level. This is the TAC dose we can see at 1 month, 3 months, 6 months and 12 months. As we bring down the TAC doses also, I think the graft function is still maintained nicely at the end of 12 months. So, to my knowledge, that who are under my follow-up and who are in my contact, I could assess up to 352 are doing well. And because many patients are international patients not under my follow-up. Acute mortality, say within the first 1 month, I had observed up to 10 patients we lost for various reasons, like infections, thromboembolisms, and sepsis. So chronic, up to, for various reasons, more than 1 month, up to 8 patients to my knowledge. And morbidity, nearly many patients who have come back to dialysis is again the problem was main drug non-compliance and drug non-affordability, and then sometimes drug non-availability, non-accessibility also in many of the neighboring countries. Tacrolimus and MMF, getting them is very difficult for these patients.
Dr. Murthy, thank you so much. I think we are little shooting over the time. Can you just wind up in a concluding point?
It's already finished. Already finished. So it is most of the donors are 65% are related, and the rest are 35% are near relatives. And so what I say is, despite being limitations, and we could still carry out a successful kidney transplant program and could offer the care in their own limited resources settings. This is my observation and experience. Yeah, this is my 200 transplantation. That is the youngest, my patient, 80-year-old boy. I have across so many countries I have clientele, including Israel, Australia, Somalia, US and UK. So I acknowledge thanks to the Kenyan government and to my management and my staff. Thank you.
Thank you. Thank you so much, Dr. Murthy. It's amazing.